So I'm Catherine Marchand, and I'm here to present. I'm here during the Open for Business Summer webinar series to discuss the challenges of managing your staffing needs post COVID-19. I'm going to talk about me a little bit further down the road, but it will be mainly about healthcare management because this is my specialty. And during COVID-19, we saw a lot of anecdotal situation where staffing could have been problematic with healthcare workforce. It's not full screen. I thought it was. Sorry, just give me. There's so many things at the same time that I see. New share, so I need this one. Okay, is it full screen now, Rosa? The first thing we need to do is the Zoom etiquette. So this session will last for 1 hour with a prompt start at 10. I'm sorry, I was a little bit late. Please, everyone, leave yourself muted during this session. Please communicate via the chat function. Any question you have throughout, we are going to try to respond to all of them. Please practice using the chat function now. So introduce yourself, maybe telling me, saying hello to fellow participants, telling us maybe what's interesting to you in terms of staffing and COVID-19. At the end, we will have a Q&A. Feel free to submit any of your questions throughout the presentation. And please know the session is being recorded. So if you don't want to ask a question, speaking during or talking during presentation, during the Q&A, just write it down and it's going to be okay with that. And please, I hope you're going to enjoy it. I know that the topic I'm presenting today is a little bit grim, but I'm trying to make it as interesting and helpful as I can. So obviously this is it's a collaboration between KBS and Center for Health Services Studies. I'm a research associate there. What we do is we do mainly research on primary health care, public health, public policy, health psychology, and palliative care. And we're expert in statistics, public engagement, clinical trial, and economics, health economics. But we also do lots of other things. I am research associate specialized in organizational behavior in bracket primary healthcare. With what that does, I'm studying workforce in healthcare organizations such as general practice, primary care, and hospital. I collaborate with KBS on postgraduate studies. I am PhD supervisor. I do MSc. I am co-director with Joseph in healthcare management, and you can find me on the CHSS staff. And if you want to learn a bit about me, why I'm interested in healthcare primarily, you can find me on the CHSS newsletter. So let's start with the Open for Business Summer. So the challenges of managing your staffing needs post-COVID-19. And this is specialized, and we're looking specifically to the healthcare professional or staff. When thinking about workforce staffing, we need to think about the following: recruitment, job satisfaction, workload, organizational commitment and engagement, well-being, burnout, depersonalization, retention, early turnover, age, and retirement. This is exactly the same thing that we would have to think about when we think about any workforce in the world, in the organization. These are the main things. Are staff well? Mentally and physically? Are they satisfied? Are they interested? Or do they have too much of a workload, etc.? In healthcare, this is all very important too. First, because we have, and this is all related to healthcare, because are issues of recruitment, there is issues of job satisfaction, and there are issues of having too many things to do at the same time. And it's super important too in terms of retention, because we see in healthcare professional early turnover. So that means that people are retiring way earlier than the age of retirement. Okay. And this is all have to be put in perspective with the needs for health professionals. So how many staff do we need? What is the demand of the population? And I'm going to go a bit deeper in that in a minute. So there is cumulative evidence that recruitment varies by specialties in healthcare. So it means it's more difficult to have a student choosing general practice versus the more sexy, if I can say that, profession as surgery and the one that pay the most, cardiology, anesthesia, etc. So there is also an aspect of gender. So women would choose different specialty because of their personal objective, but also because of the never-ending trend of having partnership, having children, etc. So women often choose specialty like general practice because it's a bit easier to manage the demand of the work and life aspect. Workload is high, and there's an increase of paperwork, reduced, and one of the worst aspects of it is that because of different element of control, of quality assessment, and the needs to have the best care, there is also some sort of reduced job control. The well-being is from low to moderate, so we have a very high level of and moderate level of burnout or almost burnout, so some trend going towards the burnout of the healthcare professional. Not every health professional are at the same level. And there's, like I said a little bit before, there's an increase in early turnover. Also, there's a very high turnover of early the first few years of being a healthcare professional. People change, decide to go somewhere else. Either they completely leave the profession, the healthcare profession that they are in, or they continue to work in healthcare, but not necessarily frontline. And obviously, the need for healthcare professionals is increasing. There's an aging population. People have morbidity, which means that they have not just one disease, but they have cumulative disease, diabetes, hypertension, etc. Okay. So the healthcare workforce staffing. So this is quite numbery slide, but what I wanted to show you is that there's over 1.2 million people working in healthcare, either as a healthcare professional, as admin, etc. I'm sorry for the email that keep coming in. And the practice nurses, so for example, in general practice, there's 34,000 general practitioners. And these are data coming from NHS Digital. So there are data that have been collected by the NHS. That's important because of the next few slides. So we have quite a big number of people working in healthcare. However, like I said, it's difficult to recruit more and it's difficult to keep them when we have done it. As I said, it is a little bit grim, this bit. The main issue we have is that the prediction are worse. So this is all pre-COVID-19. So we are in 2020, January 2020, for example, in the UK. And we were seeing a very, very slow trend that would say that actually we might be able around 2030 to have recruited in excess of a higher number of health professionals, around 100,000 FTE, so it's full-time equivalent staff. However, the need would be of 250,000 full-time equivalent. And that's an issue because we are not able, we were not able to actually get that number. It's extremely difficult, which means that there are creation of new roles that are a bit to respond to that issues. This is quite an interesting slide. And I think what's important too is that, like I said on the slide previously, is that, as you can see on the slide, is that we have one doctor per 356 people in the population versus one doctor for 277 in other comparable country, which means that we have less doctor per number of population that we need. Okay, so the King Funds in 2018 wrote an extremely detailed paper about the current shortage and the reasons for that problem. And I telling you, this is grim, but we need to understand the context of where we were before to understand where we're going to go after COVID-19. And the number and the King's Funds paper is, will the NHS make it or break it in the future? So it was also quite dramatic way to position the problem, but they found those issues that were the main important things. So the fragmentation of a responsibility for workforce issue at a national level. Not everyone has the same responsibility. Some people have more, some health professionals have more responsibility than others. Some have the ending responsibility, so it means that they have to sign out or sign in element of the responsibility while others are doing the work. A good example of it is, for example, in general practice, we have nurses doing most of the elements that are involved in the quality and outcome framework, which means that everything that is related to giving flu shots, making sure that people know about whether or not there are resources in the community for stopping smoking, etc. They are done by the nurse, but the doctor, the GP, needs to actually sign out on the task that the nurses are doing. There's also a poor working planning. So there is these are the trends that have been there since the 1990s. We knew that the population would be aging and stay longer, and we knew even in the early 1990s that actually those trends were coming, in the sense where the people will, because people die less, they have more morbidity. So we knew that. So the fact that we are still in this really difficult problem, it's just due to poor planning. There's a cuts in fundings for training places. For example, one really good scheme that was happening in this country was to have the schemes to have, there was funds for nurses to apply and study in healthcare and to become future nurses. So there was money to help people to study nursing, and these have been cut. So there was money there to help, and that really helped people who were choosing nursing, because they didn't have to have as much of a debt. But in the same time, this has been cut recently. There's also the restrictive immigration policy that are exacerbated by Brexit. And I'm sorry, I brought the B word here. Brexit is extremely, we are expecting that there might be a big impact, because we have the population, the healthcare professional population involve a lot of European staff, European immigrant, which means that might actually exacerbate those problems that we were talking about, recruitment, and making sure that we arrive to that, the level of demand versus staff professional in long term. And worrying our number of doctors and nurses leaving their job early. So these are all things that were happening in 2018, and they have been happening for over a decade before that. And that's important to know, because it means that actually we arrive in a context called COVID-19, and we are actually we are arriving in COVID-19, and we are already a little bit in a grim situation. And COVID-19 happened. We were all there. We all lived through it, and it's still happening. So we're not thinking at it on a different level. I have some cloud here that can help us remember, and just making sure that we know what's happening. So people, these were the elements that kill, people stop, discovering, overreacting, cure, create, bad. These are the kind of words we were hearing. But on the healthcare professional aspect, what we were looking at, it was more like that. Doctors are heroes, nurses are important, healthcare workers, courageous, they have commitment, dedication. We know anecdotally, because obviously we don't have the result of the studies at the moment, yeah, that I've been research I've been working throughout COVID to find data and to make sure that we know what is exactly happening since February. But so what we know is that there's these things where there's a really good commitment. If people and health professionals are recognized by the population as heroes and courageous, working longer shifts, putting themselves in front line, putting themselves at risk of getting ill. And I think this is quite an important thing because, apart from the clapping that was happening, I think there was a recognition of who are those health professionals out there. Who are we talking about when it's more about knowing who are outside, out there trying to care for people and making sure that, it doesn't crumble underneath the big weight of already administration, not enough staff, and having this weight over their head of COVID-19. And obviously, COVID-19 is interesting because there was a lot of things that were happening. What we see is the first two things are quick changes and fast adoption of new ways of working. This was extraordinary to see. We saw health professionals using technology to diagnose patients. We saw share responsibilities, changes in organization, having homework, people working from home, satellite working, having diagnosis through Skype or any Zoom or any technology that they're using. But we also saw a lot of top-bottom decisions. So policy maker saying, okay, this is now the new guideline. This is what you're going to do. And putting down to health professional to do it. And I think this is one of the risky things that happen here. So these are quite interesting things to see the adoption of technology so fast. There was some resistance before COVID-19. Some general practice were using technology already. Others were not. Everyone was using technology during COVID-19. And so if this is a trend for the future, that's interesting because actually maybe we can see more patients at a time, maybe not, okay? And this is all coming through. Everything that happened during COVID-19 is under the state of exception. This was an extraordinary situation that led people making exception to their normal working day and enormously in their professionalism, okay? So it was more about patient-centered than professionalism-centered. And that's important. Healthcare professionals are professional, doctors, surgeons, nurses, physio, mental health psychologists, mental health carer, etc. Okay, they are professionals and they are under professional. They follow association guidelines. They are, for example, the British Medical Association, for example, is giving guidelines. The GMC is telling us how the students are supposed to learn and what they should have learned in the medical school and things like that. So they are really doing it's a professional way. So you're seeing a surgeon, you're seeing a nurse, your team is constituted, the team of the patient is constituted of all those professionals. And generally there's extremely strong, and there's extreme limitation in what each of them can do, because you don't want to cross the other professional. During COVID-19, this was changing. We saw teamwork at its best. We saw nurse leading the way, telling health professional, GPs or doctors how to actually deliver care for the specific patient that we were seeing during COVID-19. So we saw nurses leading the way, and we saw changes in normal ways of working. We saw kidney specialists doing A&E work. We saw, medical professional. We saw students call, medical students, first year, second years, registrar, etc., doing a lot of call, being on call duty. Others were face-to-face still. We saw lots of different things happening, but that was all under the state of exception, because there was a moment where actually the crisis was so big that you have to actually cross those boundaries. Okay. So healthcare workforce staffing after COVID-19. So before COVID-19, the King Fund was telling us that if we want healthcare profession, if we want the issues around healthcare workforce and staffing resolved, we need to think about those 5 elements. We need to address workforce shortage in the short term. We need to find a way to have more people in the workforce. We need to address workforce shortage in the long term. So it means having more students choosing healthcare profession, education or program or courses, etc. We need to support new ways of working. So those teamwork that happened during COVID-19, well, we need to continue that. One thing that, an example of things that already happened is, for example, in end of life care, we see patients having a team of care where they share responsibility. Everyone is there to help the patient live the rest of his end of care as the best way. So we know that in some specialty, we know in some context, it does happen that the team become one, and we're all looking about the same thing. Healthcare professionals are thinking about the patient, and it's all about their own needs, okay? It's about addressing race and gender inequality in pay and progression. So we see these are still happening, and it is an issue, and it has to be resolved. And we need to strengthen workforce and service planning at the level of the system. We need to look at NHS on its own and try to find what is the best way to plan that workforce, strengthen the service planning, making sure that we're responding to the needs and being more proactive instead of reactive, okay? So this is what was happening already. We were thinking this is in the future, that's what we need to do. COVID-19 as a silver lining. We talk about the rainbows, the little kids putting rainbows in the windows. Actually, I think that, because I don't want to end this presentation on a grim note, I think we need to see what COVID-19 led us to think about. It helped us, it's a silver lining because we saw things happening that should already happen, but we saw people, putting their there's an expression in French, like you put your shirt up and you kind of go out there and do what you have to do. Okay, and this is what we've seen with healthcare professionals during COVID-19. That's why we found them so courageous. We found them, they all took a hit in there. They saw their colleagues, some colleagues dying. They saw people dying more than usual. They've been out there. So, but we saw some silver lining in them. And I think it's important to think about in a more positive way. So the first question we have to ask ourselves is, what is the new normal? Okay, we are expecting a new wave. We saw a new wave in other countries, so it might happen here. But what is this new normal? Are everyone going back to work in the workplace? No, because there's new condition. You have to be 2 meters from each other, etc. Are patients seeing health professional? Are we going back to what we were doing before COVID-19? Is this what we want to do? I think there's many things that we can discuss here. And I think this is all about how do we use the learning during COVID-19 and put them forward? How can we use effectively existing resources? For example, returner scheme. They've been there for a long time, but they were used a bit anecdotically. They were used for elderly GPs or elder professionals to come on a basis. That was quite expensive to have them. During COVID-19, retiree came back. It was more about, okay, so they need help. I have the knowledge, I'm gonna go there. It was more in a vocational care, more vocational aspect to it. Who needs to be involved in these changes? So we saw during COVID-19, during all the changes, it was top bottom. There was no time to actually discuss those changes. Healthcare professionals were being told, okay, so from now on, you're going to be working from home, and there was some discussion between them, but there was a very top bottom way of dealing with things. What we know is that in the context, during the state of exception that we were in, we saw team dynamic emerging, people working together, knowing that, we need to make sure that population's safe, that they're safe. So there was reorganization of services in a really safety way that were led by the policy making, yes, by the director of hospital, manager of staffs, etc. We saw that. But now we have to look at what we've done and our learnings and actually start discussing it together. People have good ideas. Are we going to do this dynamic aspect of blended blended diagnosis, doing some diagnosis face-to-face, others online? There's a new way to do it. And it's also the same thing about the staffing. Who do we need from now on? We saw that there was lots of nurses with lots of expertise teaching, more senior, more specialized staff. So who do we need? We need to think about that, because this new normal, the fact that we were already in a crisis before, in terms of having not enough staff, etc. How do we cope with that now? How do we do that? And one of the answers to that is that we have to be completely aware that we have to do that in a sustainable way, in a fair and inclusive way that involves trust and respect. And we need to think about the climate that we're in. We need to think about the different dynamic that we are in. And we need to think about, okay, so if we're thinking of patient care and we're actually lowering those barriers between professionals, why, we need to make sure that those barriers are being put down. And we know that in some contexts, it is like that. We know that team dynamics in surgery, in a theater, for example, in theaters, surgery, there is a dynamic that is extremely interesting, where there is a shared trust between health professionals. And this is about all the staff professionals, because if there's no trust, how can you make sure that actually the surgeon trusts the anesthetic, the nurses, the people who clean the room, for example? You need to trust all of them, because you need to be able to make sure that the patient is completely not just in the center, but people are thinking about the patient at all times. You don't want a patient that is worse when you go out of the surgery. It's that you want to have a better patient, a patient in better care. So the idea is to make sure that we have the staff that we need, that we do it in a fair and sustainable way, that we are looking at those state of exception and what we did good. What was good during COVID-19? What is a silver lining? What we learn about it? And take those new ways of working and making them and putting them on paper and making, okay, so this is how we're doing it now. And what are the next challenges that are coming in front of us, and just deal with it in a way that is instead of in a proactive way. Instead of being completely awash by this all, we didn't plan for that, so we don't know how to do it, so just, make up something. We're not going to do that. We need to be proactive and make sure that we're planning for future difficulties. So I think the main thing about this new normal is that, is it a new normal? Are we going to learn from that and go further? Or are we going to go back to what we did before, what we were doing before, which was not enough? Having a deficit of 150,000 member of staff in 2030 is extremely bad. We need to find a way to reduce those numbers. And obviously, these are not my numbers, these are NHS Digital's. So we have to learn from those numbers. And I think the silver lining about COVID-19 actually helping us to understand how effective teamwork can be, how we can all learn from each of the health professionals that were involved during COVID-19, how the community care was involved during COVID-19. I think this is how we're going to learn how actually develop a skill mix or skill mixed roles in a team that will increase the team climate, help with the engagement, commitment of the staff, increase the job satisfaction, maybe increase the control over one's jobs. That will help with recruitment and retention for all those jobs. So I know I've only did 30 minutes, and I don't know if there's a lot of people out there that have questions. If you have any question, you can start writing your question now. I'm happy to look at them. And obviously it was a short one, but I think if you have any question, we can also talk about organizational staffing in other contexts. I know quite a lot about the other contexts too. So if you have any question, just ask away. Thank you.
Hi, Catherine. There is a question in the chat. I'll read this out to you now. We know from the news that staff morale was very low at times during long shifts during the peak of the pandemic. How can the NHS and other health organisations prepare for this if we face a second wave? I
think so. We have to acknowledge that the staff morale was already quite low before COVID-19. So we are actually we arrived in COVID-19 with a staff that was already overworked, overload, etc. So this is not helping. I think there's many issues that we had during COVID-19. There was an aspect of, and obviously this is difficult because since I'm being recorded, I mean, I have to be extremely careful of what I'm going to say here. But there was a lot of different decisions that were being made. There was a lot of health professional believe in evidence, scientific fact, etc. So there was a lot of things going on that that health professionals are not allowed to talk about at the moment, and they won't be able to talk about it till COVID-19 is out of our life, isn't it? So the morale was already low. The way to do it is by actually having a team climate. The problem is that the team is overloaded and overworked and are working too long. So one way to do it is that to involve health professional in decision making. So they see that they have a bit more control over their own work. It's to make sure, the clapping is not enough. It's to make sure that they have the salary, a remuneration that is good, that they have, there's evidence that show that nurses are not able to actually, the salary of a nurse is not high enough to make them not go to food banks, for example. So we have to make sure that there's a financial aspect to it and there's a motivational aspect. So there is different ways, is to maybe bring back the fact that actually give them the time, give health professionals the time to work with patients. Most of health professionals went to healthcare in healthcare specialty for a vocational aspect. They want to help patients. They want to be there for the patient, and they want to make them better. So it means that to give the resource to health professional to do that. And it's very abstract in some ways, but it's actually very practical in other ways. If the patient, I can go on and on about the PPE, and I cannot really go on and on about it because it's a political aspect, and I'm not supposed to be political in this aspect. But there was not enough basic resource for a professional to help patients. This is extremely worrying. Imagine having to face people who are dying that could give it to you. It's extremely worrying, and people were doing all they can and they're protecting themselves. One of my students actually work in healthcare. So I work with healthcare, my students are generally all in healthcare. And one of them was telling me that, they lost one of their colleagues. And this was just for no really good reason at all, isn't it? But that's the moral is completely, and in some ways, all of this, they still did the best, the best care they could. They still deliver excellent care. And they were still quite motivated in some ways because they wanted to help patients and they wanted to make them better. So policies and stuff like that, we need to think about, well, one of the biggest reasons why in 2018 the King's Fund was saying make it or break it about the NHS was that actually, we need to fund NHS. We need to stop breaking it down and privatizing it, and we need to fund it. The way to fund it, well, it's increasing tax and getting money or prioritizing it. We know that there are some money. We know that because actually during COVID-19, there was an emergency situation and they found the money. So there's a money aspect. The moral is not about money generally, it's about intrinsic and extrinsic motivation. And I think one aspect that is important to think about is how you trust. Do you trust your colleagues to work with you and actually do it in a safe way? Do you trust the management that they are making the best decision for you? And do you actually trust the system in which you are working? Is it, are they doing it the best they could to actually help me be the safest, to do the best work I can do, the excellent work I can do? And I think these are all, it's extremely complex, but yet it's extremely simple. We need to talk to these professionals. We need to ask them, listen, what could we have done better? What can be done to help you be the excellent, continue that excellent work you're doing? And obviously the shift that they had to do was, it's tough. Like most of us, we wouldn't do that. 12 to 15. Some people were doing like weekends shift and stuff like that while they have kids, going back to home, or some were not with their kids because they didn't want to actually. So there was a lot going on. And I think we have to learn from that. Definitely. We need to talk to those health professionals and tell them, listen, how can we help you better in the future? And how can we help you trust the system, trust the management, trust that your colleagues are doing the best they could too, I think. So that would be my my short answer, which was not short at all. But it's complex. Moral is extremely complex. And we know that there are studies about burnout that are being done in the Netherlands on different topics. And one aspect is to actually do job crafting. So you are building your own job. This is something that is very difficult to do for healthcare professionals because they have to follow the professionalism that they have to follow the profession rules and laws and methods, etc. But there's ways to do maybe in the next few jobs that we're developing, the new roles, we need to be doing job crafting, okay, improving your workload, improving how you're doing your job. It's quite interesting. Any other question? It's there, it's right there.
Okay, we have another question from Salah. When do you think the question about staffing level will be raised?
If I understand well your question, I think it's quite, the main thing is that it's always being raised. We are always thinking about it. Like it's been, since the 1990s, people have been talking about the staffing level. The problem is that at the moment, people did more, which means that actually they did more, they did better, and in an excellent way, which means that actually we could see that, we don't need those people, isn't it? Do we really need them? Because, we had that number of staff and they made it work. So we have to be very careful. I think at the moment, the minister, the health secretary is thinking about it, has been thinking about it. The last ones were thinking about it. General practice or thinking community care, everybody's thinking about it. The problem is how do we budget these new roles and this new staffing level? And I think people think, oh, should we compare ourselves to other countries? Should we think about how the others are doing? Well, yes, we should. The evidence shows that the UK is not doing great in terms of its levels are quite low compared to other comparable country. So we need to think about it. People are thinking about it, but we're not really doing anything about it at the moment. So we are sometimes, some people will say, yes, we're creating those new jobs, we're creating those new roles, but we cannot think about new roles that are going to be, because we're at the moment, we're always thinking short terms. Well, I have more patients in my practice, so I'm going to hire a new nurse. Well, we need to be proactive. We need to think about, okay, so this is the trend at the moment. So how can we project what we are going to need? And it's difficult to do that because we don't have the budget and we don't know it's going to be coming in. We don't know if it's going to happen. So we are thinking really in silo too. We're thinking, okay, in my general practice right now, I need one phlebotomist. That's what I need, because the last one left and it ended up, I had no one to take the blood of my patient. Well, actually, any nurses in that practice learn how to draw blood. They were able to do it, and every doctor did it too. So actually, maybe becoming a little bit, extending our roles a little bit for emergency crisis. But we have to think, looking at trends, and the trends are not really great, isn't it? Because people are getting older, we're surviving anything. It's quite interesting. It's a quite big dilemma because everybody's thinking about it, but do they do it? And that, I think, the main / worst problem we have is that we think about it, but we're doing short-term decision about it. And that's a problem because long-term, it's not, the long-term is not that far. We're not talking about 50 years, we're talking about 10 years in front of us. So yeah, and it's also extremely political in some way because every change of government is actually making decision on, well, do we really need those patients, those doctors? Do we really need those nurses? And the idea is more, obviously we do need them, but we also have to realize that training a doctor takes 7-10 years. So we need to train them now to make sure that in 10 years we have them. And that's very complicated. So that's why I say people are thinking about it. There are some decisions that they're being made. We have more places in general practice, in medical schools. We have new medical schools. There's one in Kent now, Kent Medway. There's more all around the country. So we have more medical school happening. So that's good because people are going to be trained with them this 10 years, but that's not enough. And that's the issue. We need more, we need specialists from all around the world. We need to have a more varied professions. I don't know. They're thinking about it. People are thinking, I'm researching it. We have budget, there's research project happening at the moment, trying to look at how the team can be, all the skills that we can have in a team. We're thinking about group dynamics. We're trying to see how we can improve the morale and also better care and having, evaluating those new roles and seeing how they impact the patient care, etc. And I think that's important that it's happening, but we also need to have more places in medical school. We need more places in nursing. We need, we need back that money that was given to future, the bursary they were getting. We need that back. We need a lot of things that will allow to resolve those situations, those problems of recruitment and retention. I think the other problem with retention is that we see people starting a profession and not liking it and leaving, or leaving 10 years before they retired. And that's quite alarming. Some people say, I never want to look at a patient again. I never want to work in healthcare and stuff like that. So we have to kind of see how we can help these people to actually stay in the profession, at a better care, at a better way to deal with patient. We need that patient to health professional to find their vocation back to, like why they decide to help patient at the beginning, where they're going to go after. Okay. Is there any other question? I'm not sure if I respond to it though, but yeah, so I hope I did.
So we have another question. Catherine, with the UK heading into recession and other industries struggling, will we see a rise in people actively looking for roles in healthcare or to perhaps retrain as there is such a high demand?
I hope so. I hope so, because we do need more people in our profession. And I'm saddened by the fact that we are entering a new recession cycle, and we are in a very vulnerable with all the people who were laid off during COVID-19. And I think this is quite alarming, and we have to think about that. I think the main issue we have is that retraining is extremely expensive. So you have to have the money to retrain. And that's going to be an issue. So it will be a question of having, ideally, I would love that. I think that would be a really good way to actually resolve those issues, using people in the community and bringing back, giving them jobs and helping them go back to work. And maybe that will reduce the problem. It's extremely expensive to student in the UK. So if we're thinking about, if we're thinking about retraining, well, it means that you need to have like a £9,000 in the bank to do an undergrad. So you have to think about that. And I think that's the main issue. So that's why we need some funds to help people retrain, or, apprenticeship can be a good thing. So you could actually find, if people were at risk of losing job, or if they want to retrain, or if there is things in place in the organization for them to actually come back, that would be a solution. One of the many solutions we need to actually retrain people that are losing their job in other industry to go and work in healthcare or in community care or in social care, etc. That would be an extraordinary solution. The idea of doing it, it's extremely good. The problem is that education is expensive. And that would be the barrier to do that. So you need bursary, you need scheme to help that happen. And if we're in a recession, are we going to put money in that? And that might be an issue, yeah. Am I responding to that question? Is it okay? I'd like to be positive and not grim, and not looking at it as, I'm looking at it as a researcher, and I'm like, yeah, that's good idea. But unfortunately, we have these issues. Any other question? Do we know if there's question on Facebook?
Hi, Catherine. Any more questions, unless anybody wants to type a question quickly into the chat function here?
I know that because I have a little bit of time, I know that it was a little bit grim, and I'm sorry about that. The idea of improving healthcare comes from education and having more people going in healthcare profession. And this is starting now. So people have to start now if we want to resolve those staffing issues that we have. But we also have to think really hard how we're going to do that. And I think that's an interesting question. And I think it could be a research question of how can we retrain people to actually go in healthcare if that's what they want and if that's what they need, etc. And I think that's really interesting. We saw there was 100,000 people who volunteered to help with people that were isolated during COVID-19. These are people that if they don't have a job, if they have retired, they should go back. They could, if they wanted. They showed empathy. They showed caring. They show that they wanted to be there for others. These are qualities that we want in healthcare professions. So if these people were actually going back or wanting to do profession in healthcare profession, or a social care profession, that would be brilliant. Let's be honest, that would be brilliant, because we need people who have a strong empathy and are strongly caring for others. So I think if the retraining thing is very important, and I think increasing the morale and increasing the idea of how can we stop thinking about increasing the level, but just doing it, maybe that's the idea that we need, isn't it? Maybe that's clever. Those were a really good questions. Thank you for those questions. It's making me think a lot. Thank you, everyone. Thank you, Tyler, for your comment. So if you don't have any question, we are going to close the session.